Thank you, David. I think it's important to talk about precision medicine. You really need to evolve to different paradigms. We talk a lot about precision medicine in individualized patient care in terms of treatment selection paradigms. But I think we need to evolve to the next step, which is incorporating precision medicine to the actual technical aspects of thrombectomy, and that's what I'm going to try to talk about next. So here are my disclosures. This is a non-CME Stryker event. So the first thing you need to talk about is this idea that too many passes, it's equal to futile thrombectomy. It is true that a lower number of passes is a good thing. We have the first pass effect as a very important key metric in our field right now. We know that higher number of passes is a bad thing. The more passes you do, the lower is the chance of subsequent reperfusion, and the lower is the chance of good outcomes. We also know from this paper from Astor that more than 3 passes with a Stent Retriever also increase your chances of harming the patient, as much as a 10-fold increase in the chances of parenchymal hematoma. But the other thing you need to understand is that the higher number of passes is not only a consequence of a difficult clot, but it also causes a difficult clot. And this video here makes that point. So in the upper panel, you had a red clot. They are deformable, low friction, easy to remove. In the lower panel, you have a white clot. These are less deformable. The Stent Retriever can't integrate them. A lot of friction. They tend not to come out of with the Stent Retriever, but rather to roll with it. But if you look at before versus after, the appearance of the clot has changed. In fact, you have more clot compression after you manipulate the clot. And what is important here is, as you increase the degree of compression in the clot, you increase the degree of friction. So what you learn here is the more passes you give, the higher is the degree of clot compaction, which will then cause higher friction, will decrease your rates of reperfusion, your rates of good outcome, and more passes will lead to higher chances of complication, parenchymal hematomas. So some people start saying, well, more 3, 4, 5 passes, it's a bad thing. Perhaps I should stop my procedure right there. And this is a very common mistake in our field. We've done that with selection, and some people are doing that with treatment decisions as well. We need to distinguish predictors of outcome from treatment effect modifiers. And our culture is really derived from predictors of outcome. Why? Because we started with single-arm clinical trials, right? Or just series. And when you have that, everybody's treated. You comparing patient A who was treated with patient B that was treated. And then, surprise, surprise, the older you are, the worse is your outcome, the bigger is your stroke, the worse is your outcome, the higher is the NIH stroke, the worse is the outcome. Not surprising, more than 3 passes, worse outcome. However, now you are in a different age, you have randomized clinical trials, and when you have randomized clinical trials, you can compare similar patients that are treated versus not treated. Okay, that's the fair comparison to make. When you do that, you actually establish the treatment effect modifiers. Okay, what are the things that will nullify, cancel out the benefit of the treatment? That's actually what matters. And as you know, age doesn't nullify the treatment effect, nor does even a SPEC score, as you know from the recent Hermes analysis. So it will not greater than 3 passes. So greater than 3 passes is a worse situation, but it's still better than not treating the patient. You should keep persisting. But the point is, we should avoid getting ourselves in that situation. So to summarize, predictors of outcome tells us who's gonna do well with treatment. That's an important question. But the better question is, who is gonna do better without treatment? That's actually what matters, right? Is that you bring any benefit to the patient. So you should focus our decisions on treatment effect modifiers rather than predictors of outcomes. So let's talk a little bit about refractory thrombectomy. A lot of these cases, they aren't refractory. It's just technically suboptimal thrombectomy. First of all, you need to understand what makes a thrombectomy challenging. there are essentially two factors. One is the nature of the underlying lesion, the occlusive lesion itself. The second one is the vascular anatomy of those patients, but they are both factors that are individualized, are different from different patients. So when you look at the underlying lesion, you can have a predominantly erythrocytic clot or a fibrin-rich clot, very different behaviors. You're gonna discuss that. Calcific emboli, probably the worst situation. ICAD, definitely a challenge, mostly if you don't recognize and treat accordingly. In terms of the vascular anatomy, you can have tortuous access, you can have intracranial curvature and angulation, and occlusions at vessel bifurcations. How to optimize thrombectomy? I think in the anterior circulation cases, balloon guide catheter in 2020 is still a must. You know you have lower number of passes in our meta-analysis, faster procedure times, and everything you see here is statistically significant. Higher rate of first pass recanalization, full reperfusion, any degree of successful reperfusion, good outcomes, and mortality. All better with balloon guide catheter. Tan has written a lot on this topic, and balloon guide catheter is extremely powerful, perhaps too powerful. So what you see here is a balloon inflated with brisk aspiration, and you can see that you can actually collapse a stent, okay? So when you apply your aspiration, you have to do it gradually, just so you prevent this phenomenon. But if you do it properly, you can extract a thrombus that it's in the intracranial ICA by simply putting a balloon in the cervical ICA, inflating, and you can retrogradely aspirate that thrombus from a distance. That's the remote aspiration thrombectomy. So let's talk about the underlying lesion. I think it's important to understand the predominance of the composition of the clot, where it's red or white, with the understanding that a lot of these cases are a mix. First of all, can you tell them apart? And the answer is, on average, kind of. And this is the work of David showing that dense MCA and the blooming artifact on CT and MRI, respectively, correlate with the degree of erythrocytes. So dense and blooming mean more iron and more erythrocytes. And on average, that works, but when you look at the individual situations, there are outliers. There are technologies that may help us with microsensors in wire in the near future, helping understand that better. But why you need to know this? Well, here is an erythrocytic thrombus. First thing that you need to highlight is, again, this heterogeneous nature of these clots. But when you look at an erythrocytic thrombus, typically you have the fibrin strands, they are not as much tied together because the erythrocytes, they disrupt the fibrin matrix, okay? And that creates different mechanical properties. On the other hand, when you have erythrocytic port thrombus, mostly fibrin, that's a much more mature, cohesive, well-integrated thrombus. And this will create different mechanical characteristics across these two types of thrombi. And I believe there are three specific mechanical characteristics. They are opposite in red versus white thrombi, okay, that helps us making decision as to whether we should start with a Stent Retriever primarily or first-line strategy with contact aspiration. First one is deformability. Okay? The degree to which applying a force will change the shape of the structure. And you know that erythrocytes are highly deformable, so erythrocytic clots will deform more easily, and the struts of the Stent Retriever will permeate the matrix of the clot more easily. However, erythrocytes disrupt the fibrin matrix, right? And then you start to have problems with friability, which is the tendency that a solid has to break apart in small pieces and fragment when you apply a force. Finally, we need to understand the friction, which is the resistance to movement of one surface over another. And these three elements are very different in clots of different nature. How did you come up to these conclusions? From simple observation. We always thought that you should treat clots differently because the friability of the erythrocyte clots, you always start with a Stent Retriever, okay? And you took pictures of these clots, and you saw that with Stent Retrievers, you typically have these red blood cell clots. But then we use primary aspiration alone for your refractory cases. And you notice that when you had pictures of refractory cases, they look like this, cohesive fibrin-rich clots. So the erythrocytic clots, why I do not start with aspiration alone, because they are very common. I understand there is this data saying that it's no inferior and all that. We need to highlight that only 40% of the patients in COMPASS had a BCG, which we explain it's a must. But I want you to understand a few things here. Fibrin-rich, erythrocytic. See different behavior with aspiration, okay? So what aspiration does, it grabs the clot by the head, right? But it doesn't control the tail of the clot. So if this is a friable clot, a clot that has the tendency to break apart, to fragment, you are not controlling the whole length of the clot, and you're gonna have distal emboli. The other thing that's important that we understand here is even though you think that these catheters are big, they are far from big enough. ID of the MCA 2.7, 0.68, 1.7, 0.74, the biggest you have, 0.88. Okay, that's diameter. Let's go to cross-section area, which is what really matters, right? That's what the catheter and the clot see in terms of each other. When you apply the area formula, here is what you have, okay? The 0.68 covers less than 40% of the cross-section area, and our biggest catheter, less than 50% of the cross-section area of an M1. So you are far from covering the whole area and having good flow control or being able to aspirate a clot that can easily break apart. The other point you understand here is, again, erythrocytic clots, they break, right? They are friable. However, fibrin-rich clots, they are cohesive, and they will cork out with the contact aspiration as a unit. This is an experiment from our colleagues from Neuravi to exemplify, illustrate the friction forces, very low friction forces with erythrocytic clots, very high friction forces with fibrin-rich clots. Why this is important? Well, if you look at the ability to deform and friction forces, you can easily understand that a red clot, it's soft, easily deformable, it's gonna go through the struts. On the other hand, a white clot, it's hard, okay? It does not deform, so what it does, it pushes the struts. In this situation, you have high incorporation through the struts with low friction. The clot will move with the stent retriever. In this situation, you have low incorporation, the clot is outside with high friction. The clot will roll through the stent retriever. So this is a great contact aspiration. This is a great stent retriever clot. And here you can see again the two different nature clots. See, the stent retriever in terms of this clot, this will roll, versus the the erythrocytic clot, it's deformable, it gets incorporated, low friction, it will come out, okay? So again, the non-deformable versus deformable property, along with the friction and the friability, really tells us that you should be thinking about different strategies according to the different nature of the clot. Small word to say that BCG benefit doesn't only apply to stent retriever, you should be using it in thromboaspiration. You can see here many benefits in terms of all these different metrics of using balloon guide catheter in conjunction with thromboaspiration as a primary modality. Here is another paper demonstrating that the use of balloon guide catheter across the two techniques was related to higher rate of reperfusion and better outcomes, regardless the first modality that was used. There are improvements of thromboaspiration. You need to understand that you now have better catheters, we have discussed that. Bigger catheters, more aspiration power. However, you are still far from achieving flow control, as you demonstrated before. Here, if you have a 3 millimeter diameter vessel, that's actually 3 times the area of a 0.68, for instance. The future is bright. The catheters are getting bigger. Maybe you're going to be occlusive in M1 pretty soon. There are these ideas of using these funnel type catheters, so I think aspiration is going to grow very fast. But what you do right now is I think the technique to start should involve a stent retriever, and I think this is a very nice paper from Astor where they look at the 71% of their patients that had blooming artifact. Blooming artifact, more erythrocytes, more friable, breakable clots, right? So they could actually prove this hypothesis because in their paper, contact aspiration achieved a lower rate of full reperfusion, TQ2C and 3, versus stent retriever. That was statistically significant, and that actually led to a lower rate of benefit with a lower disability with the first-line use of stent retriever versus contact aspiration. So again, showing that if you have a breakable clot, starting with contact aspiration, will give you a TQ2B, but you're going to compromise on your TQ2C and 3 because you're going to have those distal emboli. Here is another paper from Asta and Tracer, again showing that with clots with blooming artifacts, stent retrievers seem to do very well. This is not necessarily novel. We know that the clot density impacts the response of TPA. This is a paper from Max Smoking a few years ago showing that with solitaire, the presence of a hyperdense MCA sign actually was a good predictor of reperfusion. In terms of comparing techniques, we recently did this series here where you look at almost 1,000 patients in our center. You look at the first pass effect, TQ2C and 3, that happened in 35% of the cases. You had hyperdense clots in about 63% of the cases. And then when you look at the whole cohort, the technique didn't really matter. The balloon guide catheter was a predictor of first pass reperfusion. However, when you look at patients that had a hyperdense MCA, stent retriever was statistically significantly associated with better rates of full reperfusion in a single pass with an odds ratio of 2.1. This is actually the forest plots actually showing that when you look at hyperdense MCA or hyperdense clots, positive, negative, there is an interaction where if you use a stent retriever in a hyperdense positive clot, you're going to have a better response. But there is a response in the opposite direction if you don't have a hyperdense vessel sign with perhaps contact aspiration having a better response, and that was statistically significant. So perhaps titrating the technique to the nature of your clot will be very important in the future. There are ways to optimize technique. We know now that longer devices are better. We made this comparison in our center where you compare the longer and the shorter device, and you look at the rates of first pass reperfusion, here being TQ2B and 3, and the conclusion was that longer stent retrievers were 2.2 times more likely to give you first pass reperfusion versus the shorter stent retrievers. But something that was very nice to see was that the association of thromboaspiration with a balloon guide catheter on top of the stent retriever give you almost 2.5 times higher rate of reperfusion. This was a little confusing of a message in the Astor trial. However, they look at reperfusion at the end of the procedure, okay? And if you actually look at reperfusion after first-line treatment, it actually shows that if you use the maximalist approach with contact aspiration, stent retriever, and balloon versus using balloon and stent retriever only, the outcomes are statistically significant better with the maximalist approach in terms of your chances of having reperfusion, okay? Obviously, in a small trial of only 400 patients, it's going to be hard to show differences in clinical outcomes. So just to finalize here, we believe that this maximalist approach is probably the best way to do your procedure, and the problem is not how you call it, but here is how you should not do this treatment. You should never bring your whole stent retriever completely inside your aspiration catheter. Why? Because you're going to have this stripping and tooth pasting effect of the aspiration catheter that has a much smaller cross-section than the actual clot, and then you're going to have these two emboli. So the proper way to do is, it's a partial resheathing of the stent retriever to just spin the clot in the aspiration catheter. You then inflate your balloon, and you take everything equally, everything as a unit. So I'm kind of going away in terms of my time here, but the final message is, because you don't really know the nature of your clot most of the time, and because I believe contact aspiration has a high chance of producing fragments with these mostly erythrocytic fibroclots, I think you should start with a combined technique of a BCG, local aspiration, and a stent retriever, just so you can lace the entire clot and control any fragments that could develop in terms of the retrieval process happening. But then if that fails, because you probably have a fibrin-rich clot, you then can rescue that with an aspiration-only technique. And I think that's the more reasonable approach to do this procedure. The other thing you need to understand is, which in the future will be very interesting, is refractory thrombectomy many times are caused not only by hard clots, but by atherosclerotic disease. So understanding the risk factors of atherosclerotic disease and considering in the future trials for intracranial stenting in the acute setting, I think it's going to be very helpful as well. With that, I'll conclude. Thank you very much for your attention.